Good morning, everybody. So today we are going to finish our lecture on personality disorders, including some discussion of what the new version will look like. And that's our last lecture for the day, for the semester. So if you feel comfortable and confident with your media project grade and your 3 exam grades so far, and you feel pretty confident about your presentations, typically people get in the A or high B range on those, you do not have to take the test on Tuesday. And in fact, you do not even have to come to class on Tuesday. Use it for whatever else you need. If you're not sure, you can take the test on Tuesday, and if that's your lowest score, that's what I'll drop. So it's really up to you in terms of what is the best way to use your personal time at the end of the semester. But I'm willing, I know I have at least one email from a person asking me to help them weigh it. I'm going to respond to that today. I'm willing to do that for anybody else who wants to kind of like weigh the pros and cons of it, because I know sometimes you can get in your own head about that. I certainly did in grad school when I would have the option to take a test or not. At one time, one of my friends told me I had to not take the test because it was exposure therapy to let myself get a B in grad school, which I loved. It was very cognitive behavioral. You know, there are reasons why one or the other might be better for you personally, and I am not going to judge either way. I'm giving you this option so that you do have some flexibility going forward. Alrighty, I'm just checking in everybody who's here, and we'll go ahead and get started before we do any questions about what's coming up. So Tuesday is that exam 4. It's just the 2 chapters. No, that's a good question. You don't have to let me know ahead of time if you're not going to take the exam. Just don't show up on Tuesday. You know, on the other hand, if there's a reason you can't be there on Tuesday, but you need to take the exam, let me know ASAP, because if you're not there, I'm just going to assume you chose not to take it. So, and make that your exempt grade. And then our presentations are scheduled for, and I'm going to look it up on my calendar to make sure I have it correct. I know it is a week from Tuesday. It's the last day of exams, of course. So that's the 4th, May 4th. And it's scheduled at 8, but I'm going to have us start at 9, just because 8 is brutal. With the number of groups we have, we can get through it between 9 and 11, no problem. Honestly, you can probably get through it between 9 and 10:30 without a problem. I think that everything will fit quite well within that framework. Yeah, and so I know I am meeting with a group today and another one tomorrow, and then everyone I think will have met with me, so we'll be good to go and all set up for those. And clearly I'm available via email, or you know, if you want to set up a one-on-one meeting with me between now and then, you all know how to do that, because you actually were my first class that everybody was really on doing those meetings with me, which is awesome. So I know you all know how to do it. So, and going forward, I think that I will offer both that as an option, as well as in-person office hours, or, you know, scheduled meetings, just because there might be a time where you're off campus, but it's the best time to meet with me. So. Alrighty, and I just realized I'm talking away, but I haven't actually opened the PowerPoint, so let me do that real quick, and then we can dive in. So if you remember, we got through the cluster A disorders on Tuesday, so we're starting with the cluster B. The cluster B disorders are the most common ones you run into, to be perfectly honest, with the exception of maybe like 1 or 2 of the cluster C ones. So we had just one more slide for the cluster A. So I'm going to go ahead and share screen. Okay. All right. So the people argue that the cluster A personality disorders are really on this sort of spectrum, where essentially The least like schizophrenia is paranoid PD. The most like schizophrenia is schizotypal. I believe, and we'll revisit this when we get to the part about these disorders. Sorry, I have this moment like brain fart. When we get to the part about how they're revamping the personality disorders. I believe schizotypal is the only one they're keeping, actually, interestingly. So there's going to be a pretty big revamp. Again, hoping that the little APA actually, lets them do what they want to do. Alrighty, so the cluster B are sometimes called the dramatic personality disorders. And these include some of the ones that are most often popularized in media. So antisocial personality disorder, also known as psychopathy or sociopathy. Just like side note that those are not diagnostic terms. So both of those would fall under antisocial PD. So if someone came in and they were a psychopath, they would get antisocial PD as their diagnosis. Borderline personality disorder, histrionic, narcissistic, and the key features here are that their behaviors are so dramatic, emotional, or erratic that it is almost impossible for them to have relationships that are truly giving and satisfying. These are, again, among the most commonly diagnosed. That being said, only antisocial and borderline have received a lot of research attention. The causes of these disorders are not very well understood. All right, so we're going to start with antisocial PD. So these people persistently disregard and violate the rights of others. So just like when we were talking about the paraphilias, antisocial PD is a case where that person can be diagnosed even if it's not they're not disturbed by their own behavior. It's enough that other people are. Aside from the substance-related disorder, this disorder is the one that's most linked to adult criminal behavior. The DSM requires that a person be at least 18 years of age to receive this diagnosis, and that is true of all the personality disorders because we don't want to over-pathologize someone under 18 who might just be falling in with the wrong crowd, or, hormones and social issues are getting there. But most people with antisocial PD displayed some pattern of misbehavior consistent with this disorder before they were 15 years old. And in fact, there are 2 disorders of childhood that can be diagnosed sort of prior to this. One is oppositional defiant disorder, and the other is conduct disorder. And conduct disorder is essentially the adolescent version of this. So they are intelligent, but very lacking in judgment. They're very sharp, quick, and with it. They sort of put on a mask of sanity. They can kind of blend in. They're able to erect a good front. They often are very charming, likable. They seem spontaneous, but they're like actually planning things. Humorous, upbeat, and optimistic. If anyone's ever seen the show Dexter, this is actually a really nice portrayal of someone with antisocial PD. I show this to illustrate antisocial PD in Psychology and the Law. So he, if you're not familiar with the premise of the show, he is a serial killer who only kills criminals who get away with things. And so he works at a police station, which is interesting for a serial killer, right? And he is nice to everybody, and he brings everybody donuts, right? But he talks about having to ape their emotions because he doesn't actually feel them. They have what has been called an inadequate conscience. They are just morally deficient. They don't feel remorse or guilt. They don't feel what we call anticipatory anxiety. If you or I were to go, commit a felony, we would get really anxious about oh, what if I get caught, blah, 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 right? They don't get that, which is one of the reasons why they get away with stuff for so long, because they're frankly good at it. They're also emotionally unaffected by punishments, which means sort of rehabilitating these folks is really difficult. So they have intelligence and social shrewdness and lack of conscience, and this makes this like sincere deceitfulness. They are irresponsible and sometimes impulsive. They're narcissistic, they are sensation seeking, so they have to do, almost like someone who's using drugs, they have to do more and more intense things to try to experience any basically serotonin release in their brain. The reality is for their gratification. They reject authority, and as I mentioned, they're unable to profit from the experience. They reject the rules of the game. They often have an erratic social history. Sometimes they've been labeled as having historical stupidity because they don't learn from past mistakes because of that lack of remorse. They have an inability to maintain true interpersonal relationships. So they're socially facile, but they're interpersonally delayed, basically, like they just don't understand. They tend to be egocentric, cynical, and remorseless. They're likely to lie repeatedly, be reckless, sexually promiscuous, and impulsive. And they have a disregard for other individuals and can be cruel, sadistic, reckless, and violent. And so I actually have, I'm going to do a new share. I have a YouTube video that just shows, actually there's a whole series of these if anyone is interested. This is interviews with someone with psychopathy. And so I thought it'd be interesting to watch the part where she talks about whether or not she's dangerous.
Would you say you're a dangerous person?
I don't think of myself as a dangerous person. I think that I can be dangerous for certain people through no fault of my own. You know, I think if people expect me to behave a particular way or something, I think that it's a little bit of a misconception that psychopaths are predisposed to violence. I don't think there's necessarily a predisposition there. I think just the certain limitations that normal people would feel, you know, like they don't want to, you know, guilt, shame or whatever. They don't want to disappoint the people around them. They're image conscious. They care what other people think about them. They're worried about the consequences. You know, if they're young, they're worried about, you know, getting expelled, or they're worried about their parents finding out, or they're worried if they're older that they're going to go to jail. And I think if you just take all those away, then do normal people engage in violence too? Probably about the same rate, you know, that psychopaths were, if you were able to take those all away. Because we do have these examples of, you know, like normal people, if they get angry enough, or if for some reason they don't care enough, then they also do those things. So I don't think there is that kind of predisposition to violence at all in psychopaths. I think it's just that it's easier for them to do anything, I think, that's kind of contrary to social expectations. And that includes violence. I think that one of the reasons why I have not engaged in violence probably as much as other people, and it, you know, I know other successful, let's say, sociopaths, psychopaths, who do have engaged in violence, you know, who do have multiple convictions for assault, but are still like normal functioning, you know, have good jobs and still do these things. But it's just, you know, when push comes to shove or whatever, they were just raised in like a different culture. Like where I grew up, like kind of a little bit more hippie culture in California, you know, violence is not really a thing that you would do. I think also kind of being female, I never really felt like that was going to be, you know, a good good way for me to assert myself, because I'm not that big, you know, I'm 5'4" or whatever. You know, that hasn't stopped some other female psychopaths I know, you know, they're 5 foot or whatever, and, you know, like taking on dudes that are 6 foot, you know, with a knife or whatever. If I were in a situation in which violence was called for whatever reason, then I would engage in violence probably. And I just got in kind of an altercation this way. It was like a political dispute. I didn't realize that the other person was getting angry, so I just kept talking, which was my mistake. And they started saying, hey, you know, I'm going to beat you up, basically, you know. And then I thought, well, okay, I guess you can beat me up, because honestly, I would just take the punches too. And it's not because I'm like kind of morally superior. It's just because I don't care. I don't care about like the physical altercation. I don't care about not engaging in it. You know, I would be like, fine, beat me up if you want to, I guess. You know, that's fine. I wouldn't fear that sort of thing. And sometimes something would bother me a lot psychologically. It would trigger me into what I'll call gray rage. It's actually a term that another psychopath came up with, so I just borrow the term, although it applies to me. And gray rage is most reliably triggered when somebody who doesn't have authority over you tries to assert authority over you in a particular situation. And another psychopath friend says it's when people have a false sense of their own authority and a false sense of their own personal safety. And I think that's what triggers it. Then you think, I'm going to correct this person about their false sense of authority and safety and make them fear for their safety and make them realize they have no authority over me because I will take it to the nth degree, including violence, in order to kind of correct them of this misapprehension. So gray rage, it's a very cold, like that's why it's called gray, not red, not even blue or whatever, just a gray rage in which it's almost as if like when you're gray raging, you feel very not yourself, very not kind of in control, almost like a fugue state, like this is just what's happening. And I have experienced that a couple times. Luckily, when I have gray raged, I have never been able to actually track down the intended victim in time to do anything. And even if I did track them down, what could I have done? You know, I'm 5'4". I don't think I could have hurt them very badly. And I think it is something that you quickly snap out of within maybe, you know, at least an hour, you know, and often like 5 to 10 minutes, you kind of snap out of it. I don't know why that is a pretty common trait for psychopaths to feel. And I think that this is probably, though, why people do end up in prison. Especially, it's pretty impulsive and it's pretty kind of, you're not thinking about any consequences. You're almost not, you don't even feel like you're making the decisions yourself. You just feel like you're kind of acting in this particular way. And, you know, it's just like you're fulfilling an almost destiny. And it's a very unique experience. I probably experience it maybe once every, back when at my playground stage, maybe once every year, once every 2.
All right, so there is a nice example of just how different these folks are from us, right? Like, I don't know about y'all, but as I was listening to that, it just feels super foreign to me. Like the idea that if someone threatened to beat me up, I'd be like, sure, because I don't care, right? But they just have different ways of interpreting things. Surveys indicate that up to 3.5% of people in the US do meet criteria for this disorder. This is one where people have it, they don't suffer from it. Caucasians are more likely to be diagnosed than are people of color. It's 4 times more common in men than women. Part of what we think is going on there is exactly what she was talking about, the idea that like violence isn't necessarily an acceptable way for women to react to something in our society, even if you're a psychopath, right? So they tend to lash out in different ways, whether it's backstabbing, manipulation, what have you, to maybe sabotage someone's career instead of, you know, murdering them. It's much more common in prisoners than in the general population. Studies have shown between half to 80% of men in jail would meet criteria. So where are the rest? Well, the idea is that the good ones don't get caught. That these folks are maybe the folks on Wall Street who caused the housing bubble, right? Things along those lines. They do have higher rates of alcoholism and other substance-related disorders. And in terms of treatment, only about 1/4 of people with this disorder actually receive treatment, and nothing really works. No treatment seems to be effective here. A major problem is that lack of conscience or desire to change that I talked about and that you heard the person with psychopathy articulate. So if you don't care, right, you have no motivation to actually change. You might pretend to change, right, and actually not. And a lot of times, if someone with psychopathy does go for treatment, it's mandated by the court. And we know in general, when people are mandated to therapy, it's not as helpful than if they choose it themselves. So some cognitive therapists try to guide clients to think about moral issues and the needs of other people. Hospitals have attempted to create therapeutic communities. So I've been reading the book, The Psychopath Test, which looked at some of the history of this disorder. And there are some bizarre things they used to do. Like we were talking about substances being used therapeutically, like putting all the psychopaths on a hallucinogenic and putting them in a room together, right? It's just like, they had some out there ideas. But group therapy does not work. And in fact, group therapy, they get worse, not better, because they get ideas from each other. So that is like the last thing you should do with people with antisocial PD. Generally, most of today's treatments have little or no impact on this disorder. All right, so next we're going to talk about borderline personality disorder. This is the personality disorder I personally saw the most often during those 5 years that I was treating clients. And in particular, my last year, my internship year. So the reason I saw it so often is this has a high comorbidity or co-occurrence with eating disorders. And then also on my internship year, part of what I did was learn the treatment that has been devised particularly for this disorder. So I had interactions with those folks that way in particular. So the symptoms here include instability of self-image and relationships. So they have what's sometimes called identity diffusion or identity disturbance. They're searching for faulty saviors. They're trying to like identify themselves based on other people. The character does not have borderline PD, but I think the best sort of like analogy for this is the movie Runaway Bride, how Julia Roberts' character always just says she likes whatever type of eggs her fiance likes. She doesn't actually know what kind of eggs she likes. So again, that character does not have this. But take that and apply it to pretty much everything in your life, and that can be what people with borderline PD experience. They have trouble being alone and difficulty being with others. They have a history of intense but unstable, tumultuous relationships. And they tend to be exploited by other people and or exploit other people themselves. And so there's these vicious circles of that. And returning to unhealthy relationships. They also tend to have a real dichotomy with how they look at other people, and this can include their therapist. So like one day you're on a pedestal, you're the best person in the world, and the next day you do one little thing wrong and you are the devil. You are the worst. So they experience emotional dysphoria and instability. So, you know, this is often comorbid with mood disorders, but this sort of goes beyond that. They're emotionally unstable in the way that we often just sort of toss around about people. Oh, they're unstable. People with this generally, like their emotions can come up to any kind of scenario. They have a difficulty managing those emotions as well. They have a baseline of dysphoria or feeling of inner deadness that alternates with sometimes violent and prolonged emotional outbursts. And typically when someone with borderline PD is violent, it is towards themselves. One of the hallmarks of this disorder is self-harm. And typically that takes the form of self-mutilation, so cutting yourself, burning yourself, things along those lines. But it certainly can include other things like some people with borderline PD who don't meet full criteria for an eating disorder will still like engage in binge and purging as a self-punishment. They tend to be impulsive, unpredictable, and sometimes destructive. They're prone to bouts of anger, which sometimes result in physical aggression and violence. But again, more often they're directing that towards themselves, inward. So in addition to the cutting and burning, it can have alcohol and substance use as a form of self-harm, reckless behavior, including, substance use and driving or unsafe sex, suicidal actions and threats. And that can be part of the scariest bit of treating someone with this disorder, to be perfectly honest. And as I mentioned, they might engage in disordered eating behavior, and this has a really high comorbidity with eating disorders in general, but particularly bulimia nervosa. So again, I have some clips here. So we won't watch, actually, let me start with this. I gotta pause this one. This is actually a clip of Marsha Linehan, who developed the big
Borderline personality disorder is by far
for this disorder. And so she actually, I think around 2011, did an interview for the New York Times and admitted that she herself struggled with borderline personality disorder growing up. And one of the reasons why she developed this therapy, which we'll talk about in a couple slides, is because no one knew how to treat her growing up. She would self-harm and they'd put her in a padded room, right? Like, which isn't really that productive. So I'm going to show you a clip of her, and then I'll show you another clip that shows a little bit more about patients.
borderline personality disorder is by far the most stigmatized disorder. I tell my patients, if you end up in an emergency room for a medical disorder, for God's sakes, do not tell them you meet criteria for borderline personality disorder. Do not tell anybody, because there's such a stigma. And you'll be treated differently most of the time. And many, many, many mental health practitioners will not see a person who meets criteria for borderline personality disorder. Watch TV sometime. They have a mass murder, borderline personality disorder. Drives me nuts.
Yeah, and she's spot on there, because if there's a mass murder, it's often not someone with this disorder. So I'm show this whole 15-minute clip, but just show you a little bit of what it's like for these folks who live with this disorder.
Hey, real quick, I know mental health is complicated and overwhelming, but MedCircle can make your next step an easy one. When you go to MedCircle,
a bipolar disorder from 2 different psychiatrists, that was incorrect.
Mm-hmm. So he's going to interview someone with borderline.
It's taken a very proactive role in her own mental health care and has fought for the right diagnosis of borderline personality disorder. This is her story.
We just talked about your whole story.
Yes.
What a roller coaster ride.
I know, isn't it?
I mean, some people think their life is tough when the food order comes in wrong, and you had a bipolar disorder from 2 different psychiatrists that was incorrect.
Mm-hmm. Yeah, it was rough.
What was that like?
It was very frustrating, because I knew there was something else wrong, and that there was something, it didn't make sense. It didn't click. Yeah. And when I finally got the right diagnosis, I was like, oh, it finally clicks. It makes sense to me.
Yeah.
You know? It was so frustrating, though.
How does borderline personality disorder affect your behavior?
There's so many, so I'll just start.
Yeah.
I'm very impulsive. So right now I have a normal hair color, but I go from not having a sense of identity. So impulsively, I will dye my hair, all different kinds of colors, because I don't know who I am one week. And I don't know, I just try and identify with different things, if that makes sense. Mm-hmm. So there's that. I'm constantly terrified that people are going to leave me, like my boyfriend. I have dealt with abandonment so much in my life that I think that has a huge, good contribution to how I am today with that. I'm constantly worried about him leaving me, or, my friends leaving me. I do what's called splitting, which is black and white thinking. So I will go from really loving someone, like one of my friends, wanting to talk to them all the time, placing them on a pedestal pretty much. And then if they do something wrong, or if they make me feel bad, or they don't text me back, I'll go from loving them to absolutely hating them, I guess you could say. And that is a roller coaster in itself. And it's like so overwhelming at times. And the way I feel, it's so intense. And that's all I can like describe. You know what I mean? Like it's such an intense feeling because people will be like, yeah, everyone gets mad when someone doesn't text them back. And I'm like, no, you may be upset, but you're able to get past it within the hour most of the time, you know? I don't know. But me, I will stew on it all day, and I'll just be like, oh, I hate them so much. Like, they must hate me. Like, they don't want to talk to me ever again. Like, and it goes from 0 to 100, and it's just crazy, you know? I've dealt with self-harm. I'm actually, like, 3 months self-harm free, so pretty
all right,
excited.
that's
yeah,
good.
So,
Very
so
good.
And that was, like, a huge thing, just, like, self-harming and hurting myself was such a big contribution to how I was doing in 2017. So there's that. And
because in 2017 you had a very depressive year.
Yes, exactly. Really, really bad.
I want to go to where we talk about in that episode.
Okay, so I'm going to stop there, but obviously there's so much more about what this disorder is like to live with. Just to give you some examples from, folks that I treated. So one of the client that worried me the most that I treated with this disorder, the month before I started seeing her, I think I started seeing her in like August, maybe July of 2009. She had been hospitalized 3 times for trying to overdose on her medication. And she had stopped what we would think of as typical self-harm, so she wasn't cutting herself anymore, but she had excoriation disorder, basically, that manifested as self-harm. So she would form scabs, and then she'd pick the scabs, right? And then they wouldn't heal, and then she'd pick them again. And she told me, like, that's my form of self-harm right now. And then I saw her for, I want to say, like 8 months or so, and then she had to move. Her husband was in the military. And I got her all set up with a therapist in her new locale. And she called me maybe a month later, and she said, I cut myself again. And I was just like, you need to talk to your new therapist about this. I can't do anything from, thousands of miles away. But that is the type of interaction you might have with someone with borderline PD, that when they're overwhelmed, the only thing they know how to do is self-harm. And then, they will sometimes use that self-harm as almost like a manipulation tool to try to get people, it's like a cry for help, basically, try to get people to rush to their rescue. Research shows that as many as 10% of outpatients and 20% of inpatients may meet the diagnostic criteria for borderline PD. Many of the patients who come to mental health emergency rooms are individuals with the disorder that have intentionally hurt themselves. Like Linehan said, if you're doing therapy with these folks, you teach them, you coach them on how to present when they go to the ER, so they're not constantly being put on like 72-hour holds. Because one of the philosophies of the treatment for this disorder is you have to learn to live in the world you're going to live in, right? So if you're constantly locked away, you're never going to get that experience. Between 1.5% and 2.5% of the general population are thought to suffer from this, and close to 75%, so 3/4 of those diagnosed are women. And again, is this like depression where there might be some gender bias in diagnosis? Perhaps. Is it linked to social and hormonal and other problems women have? Perhaps. Is it also linked to the fact that women are more likely to be sexually abused, and a lot of these folks have histories of sexually abuse? Probably, right? The course of the disorder can vary. The most common pattern is that the instability and risk of suicide reach a peak during young adulthood. That being said, when I was helping with the group for this, you do like a skills group that's like a class for them. I believe all of our women in there were in their 40s or above. So, you know, it doesn't always just stop. And why is this called borderline? What is on the borderline of? So the original diagnosis was termed this because it was supposed to be on the borderline of neurosis and psychosis. And again, neurosis being this old term for anxiety. So these folks act out, they have disturbed relationships, they have disturbances in their experience of self, which you saw her talk about. And they can have transient psychotic symptoms where they feel like they hear things, see things. They also tend to dissociate like someone with PTSD. And it's not uncommon, unfortunately, for them to also have a comorbidity with PTSD, particularly if trauma is a part of their history, as sexual trauma in particular. So about half of those who have this disorder suffer from depression or a bipolar disorder. Is it on the borderline of the other personality disorders? It shares a lot of symptoms with all these other disorders, right? So it's got the oddities of thinking and the ideas of reference, the depersonalization and the emotional chaos of schizotypal PD. It's got that demanding or attention-seeking bit of histrionic, which we'll talk about next. And they're overwhelmed by criticism and require constant attention and admiration, just like someone with narcissistic PD. And they will have an unstable history of employment, relationships, changes, and recklessness, just like someone with antisocial PD. So as I mentioned, there's a strong link to previous trauma, especially childhood sexual trauma. Some sociocultural theorists suggest that cases of borderline PD are particularly likely to emerge in cultures that are changing rapidly, that there might be something about that that influences their sense of self, for example. So how do we treat it? It appears that psychotherapy can eventually lead to some degree of improvement. It's not easy, though, for a therapist to strike a balance between empathizing with a patient's dependency and anger, or both their dependency and anger, and also as the therapist challenging the client and their way of thinking. As you can imagine, therapy termination is often quite difficult because they have these fears of abandonment. So your book claims that contemporary psychodynamic therapy has been somewhat effective. I hate to contradict your book, but no. Like, research actually shows it can make things worse and it does not work. So this is one case where, you know, doing that type of therapy is just a total non-starter. Over the past now almost 3 decades, an integrative treatment approach called Dialectical Behavioral Therapy, or DBT, has received growing research support, and it's now considered the treatment of choice for this disorder. We also talked about this briefly when we talked about suicide prevention. So it includes intensive treatment with individual sessions. In the individual sessions, you can focus on those self-harm behaviors. And then you do what you call behavioral chaining, where you trace back to see, like, where did those start, to start helping that person figure out where can they intervene in the next time so that they don't go the full way to self-harming. It also includes those group sessions, like I said, that are basically classes. They call them the skills group or skills training. And the skills in DBT are mindfulness. So being in the moment, understanding what's going on around you. Also, acceptance of distress, what we call distress tolerance. How do you cope with distress without leaping to self-harm? Emotion modulation, coping with intense emotional experiences, and also interpersonal effectiveness skills, so helping them learn to communicate effectively with the other people in their lives. In addition, most times DBT includes a third component, which is the therapist being on call 24/7 via phone. And so the client can call you anytime and say, I'm thinking of self-harming. And your job as the therapist is to coach them through, well, what skills could you use? If they call you and they've already self-harmed, you say, I'm sorry, I can't talk to you. Do you need to go to the ER? If so, do so. Because you're trying not to reinforce that behavior, right? What you're trying to reinforce is seeking help before they go to that extreme. This is very stressful. I would literally wake up in the middle of the night worried about my clients. This is honestly the main reason I am not a therapist now. There were a lot of things kind of leading up to that, but doing DBT made me realize how intensive it is and how much people's lives are in your hands. And it just wasn't healthy for me. I know DBT therapists who are like, no problem compartmentalizing, even though they're always, on call 24/7. I am not that person. So group therapy has also been of some help. Oh, one thing I should say too. So there are those three components of DBT for the client, right? Individual therapy, the group skills training, and then the phone coaching. There's also a fourth thing that's recommended when you do DBT, which is support for the therapist, because this is exhausting. So typically you are supposed to have essentially like group supervision with other therapists doing DBT to support each other. And actually I would imagine in this age of like Zoom and all that, that it's easier to find people who are doing it. This is a case where medications have helped, but typically for people who have comorbidities, but antidepressants, mood stabilizers, anxiolytics, antipsychotics have helped. However, given the high risk of suicide attempts by these patients, you have to be really careful about what they're on. So Linehan herself has a phrase where she says, no lethal drugs for lethal patients. She believes that they should be given something like the SSRIs they can't overdose on, for example. Often these patients benefit from a combination of drug therapy and psychotherapy, particularly DBT. All right, so we're going to talk about histrionic PD. And so people with histrionic PD are extremely emotional and continue to seek to be the center of attention. They engage in attention-getting behaviors. They really want approval and praise. They're described as vain, self-centered, and demanding. They sometimes go to the extreme of making suicide attempts to manipulate others. Mostly we see that confined to borderline PD, though. This was once believed to be more common in women than in men. However, research has revealed gender bias in past diagnoses. The latest stats suggest that around 2% of adults have this disorder, with males and females equally affected. Social cultural theorists believe this disorder is caused in part by society's norms and expectations, and that these might be an exaggeration of what's expected from people who are feminine. So they often come to treatment on their own, unlike people with a lot of the personality disorders that we've talked about, because it's another way to get attention, right? Working with them can be difficult because of their demands, tantrums, seductiveness, and attempts to please the therapist. So CBT therapists try to change beliefs that they are helpless, or try to help them develop better, more deliberative ways of thinking and problem solving. Here is one case where psychodynamic group therapy is helpful. And drug therapy is less successful unless, again, they have a comorbidity. Narcissistic PD, people with this disorder are generally grandiose. They need a lot of admiration, and they feel no empathy for others. So the name for this, if you're not familiar, comes from the myth of Narcissus, which is what this painting is, who just like was so obsessed with his own reflection, right, that he spent all his time looking at it. They are convinced of their own great success, power, or beauty, and they expect constant attention and admiration from those around them. Now, interestingly, a lot of times anxiety underlies this, right? Because they put on this good front, but really they're like anxious other people will like them. So I've only seen one person with this disorder, and I got to use my free pass and pass this off to somebody else. Oftentimes we do an intake and pass them to someone else. And I was really grateful. And he benefited a lot from seeing my friend, actually. So, but typically our intake interviews in our training clinic were an hour. And when I asked him, tell me about what brought you in today, he went on for 3 pages worth of notes. He told me he was writing the next great American novel. He had not even a title page actually typed up. He had to bring in his art and his poetry to show me how awesome he was. So it's definitely an interesting vibe with these folks. So they exaggerate their talents and achievements. They often appear arrogant. They're seldom interested in the feelings of other people, and they may take advantage of others to achieve their own needs. This is fairly rare, less than 1% of people, and up to 75% of those diagnosed are men. And again, this is a disorder that we don't want to diagnose until adulthood, because these behaviors are actually pretty common among your average teenager, I would say, particularly in our social media driven world. Here is another one where treatment just doesn't seem to work. Clients will come in for a related disorder. I think the guy I saw had some depression, and that's why he came in. They'll try to manipulate the therapist in supporting their sense of superiority. So again, if you don't feel you need to change, you're not going to. Yeah, some memes about this, right? All right, so anxious personality disorders, the cluster C. So these are most likely anxiety disorders, and they include avoidant, dependent, and obsessive-compulsive personality disorder. They're typically anxious and fearful. Many of the symptoms are similar to those of anxiety and depression, but there's no actual links between these and what we used to call the Axis 1 conditions. As with most of the PDs, research is pretty limited, but treatments do appear to be pretty helpful here compared to the other PDs, partially because we can take those treatments from anxiety disorders and adapt them. So avoidant personality disorder. People with this disorder are often very uncomfortable and inhibited in social situations. They're overwhelmed with their feelings of their own inadequacy and extremely sensitive to negative evaluation. They believe themselves unappealing or inferior, and thus they tend to have few close friends. This disorder is similar to social phobia or social anxiety disorder, and you can be diagnosed with both. The similarities include a fear of humiliation and lower self-confidence. But the key difference is that people with social phobia mainly fear social circumstances, whereas people with avoidant PD actually fear close social relationships. They fear getting close to other people. People with this disorder come to therapy seeking acceptance and affection. Keeping them in therapy can be challenging because they start to avoid sessions. A key task of the therapist is to gain their trust. You also want to treat the disorder like you treat social phobia and social anxiety, and the treatments do tend to have modest success, and an anxiolytic may also be helpful. All right, dependent personality disorder. People with dependent PD have a pervasive, excessive need to be taken care of by others. They tend to be clingy and obedience. They fear separation from their loved ones. They rely on others so much they cannot make the smallest decisions for themselves. So this was actually really interesting. So the client I described to you before, who had borderline traits, who tried to kill herself 3 times before I started seeing her, she also had dependent traits. And so she, as far as I know, had never actually worked, which like no judgment in and of that, right? There are certainly people who don't. But her husband gave her an allowance, like she was a kid, and she like sort of required people to take care of her. She had COPD, which is a lung disease, and she was on oxygen for that. But she would smoke while wearing her oxygen tank. So like another form of self-harm for her borderline traits, but also, you know, again, like making herself really dependent on other people telling her, you know, things that, you know, don't do that, right? I remember when she was transferred to me, her former therapist told me, don't hug her. And I was like, I wasn't going to anyway. But it turns out she had previously had a really inappropriate therapist who part of her therapy was to like snuggle the client during therapy. So I worked on like a nice firm handshake as a way of like affirming that we could have some connection without, you know, again, also setting appropriate boundaries. Because people here that have their central feature is the difficulty with separation. They tend to feel distressed, lonely, and sad. They often dislike themselves. They're at risk for depression and anxiety, and may be especially prone to suicidal thoughts. They think it's somewhere at like 2% of the population, and men and women are equally affected. So how do we treat this? So in therapy, people with this disorder usually place all responsibility for their treatment on the clinician. The clinician just needs to magically fix them. And in fact, the key task is helping clients accept responsibility for themselves. Couple or family therapy can be really helpful to help the partner understand their dependence, right? Treatment does seem to be at least moderately helpful. Psychodynamic treatment here focuses on similar things they do to folks with depression. Cognitive therapists try to help clients challenge and change their assumptions of incompetence and helplessness. So like their core belief tends to be, I'm inadequate and helpless to deal with the world. And sort of a corollary is, I must find a person to provide protection so I can cope. Antidepressants do seem to help, particularly when this is exacerbated by depression. And group therapy can be really helpful because it provides clients an opportunity to receive support from a number of peers, and because group members can serve as models for one another. All right, OCPD, or Obsessive-Compulsive Personality Disorder. So this is pretty distinct. Oh, sorry, did someone have a question? Yeah, thought I heard something. Could just be a Zoom blip. So people with OCPD are preoccupied with order, perfection, and control. And they're so preoccupied with that they lose all flexibility, openness, and efficiency. They set unreasonably high standards for themselves and others, fearing a mistake, and they may be afraid to make decisions as a result. So one of my first clients, believe it or not, had this disorder, and so she was a challenge. If I gave her homework between sessions, she would tell me things like, I thought this was stupid, but I did it anyway. Or she would white out her homework and rewrite it, so it was perfect. I started giving it to her on colored paper, and that kind of helped a little with that. She told me she had a 1 strike and you're out, maybe 2 strikes and you're out policy. And I was like, that's not even how baseball works, right? And why this picture of a closet is on here is because she would organize her closet by color and sleeve length, which, like, there are people who do that, is fine, whatever. But why it was maladaptive for her is, let's say her friends were going out to dinner on a Friday night. If she had laundry to put away, if her closet wasn't perfect, she wouldn't go out with them and would stay in and spend hours organizing her closet instead. So very, very difficult. They tend to be rigid and stubborn. They have trouble expressing affection, and their relationships are often stiff and superficial. They think somewhere between 2 and 5% of the population be criteria here. More men than women are diagnosed with this, but obviously women do have it. Clinicians believe that this might be closely related to OCD. However, research has not actually found a link between them, and they don't really have a high comorbidity like you might expect for that. People with this disorder usually don't believe there's anything wrong with them, so they're unlikely to seek treatment unless they're also suffering from another disorder, most frequently anxiety or depression. That certainly happened with my client. She originally came in due to a death in her family. And she also had some generalized anxiety disorder that we worked on treating. Although drug therapy and behavioral therapy have been effective here, they respond better to psychodynamic or cognitive. I did CBT with her, so we did behavioral things as well as she is the client that I probably got the furthest in CBT in terms of like needed to really drill down to figure out her core beliefs. And she, oh my gosh, she was so rewarding because she did change so dramatically. So she started seeing me, I think, like 1.5 years before she graduated. And she had options at that point of whether to take like a really high stakes, high recognition job in a major city or to stay locally and work for the company that she had worked for in the past and really liked. And at the beginning of therapy, she would have certainly taken that high pressure job. But at the end, we did some pros and cons, and she decided to stay in the area because that's what would make her happier. And she didn't feel the need to judge herself by what other people would think of her. So like that was so huge and so rewarding to see that actual change happen in her. All right, so what were the problems with these DSM-4 categorizations that we're still stuck with? So one of the first problems is that they are categorical, right? You're trying to slot people into these categories, when in reality, there's a lot of evidence that personality disorders are on a continuum with normal personality, meaning that these are probably just extreme versions of normal personality traits, quirks, what have you. There's so much comorbidity between personality disorders, meaning that people who are diagnosed with one disorder are commonly diagnosed with more than one, or might be diagnosed with personality disorder not otherwise specified because they have traits of many different disorders. So this suggests there might actually be fewer personality disorders that would adequately account for all the variations of symptoms. So the DSM probably has too many personality disorders. And then diagnosing a personality disorder using the DSM criteria requires information that's actually really hard to get as a clinician. So you're supposed to have accurate info about how this individual treats other people. Really hard to tell, right? Information about how they're behaving in a wide variety of situations. You're only seeing them in your office. Romina, I see your question. So remember I talked about on Tuesday that for the DSM-5, they copy pasted the DSM-4 categories. So this is still a problem. And the new ones that are in the appendix at the back seek to correct some of this. So hopefully the DSM-6 or whatever we do next will rectify some of this. Yeah, good question. Yeah. Let's see. You also are supposed to have information about how stable their behaviors have been since childhood or adolescence, right? And if you're working in a managed care facility where you're taking insurance, you have to diagnose this disorder within your first hour or maybe hour-and-a-half interview with the person. Really, really challenging. Really, really challenging. This is one thing I really did learn from doing the DBT therapy, is how to diagnose a personality disorder fairly quickly. But it's still really hard. In fact, when I was in my training clinic, we were not allowed to diagnose someone with a personality disorder until we had seen them for at least 3 therapy sessions after the intake, just to make sure we had the right information. But again, if you're billing insurance, you need to have a diagnosis right away. Also, as I've already hinted at, there are some gender biases in the diagnoses. So some personality disorders are more frequently diagnosed in women, like histrionic, dependent, and borderline. And what psychologists have argued is that this occurs because these disorders are essentially extreme versions of negative stereotypes of women's personalities. So flamboyant behavior, emotionality, and dependence on others. The ones that are more frequently diagnosed in men, like antisocial, paranoid, or OCPD, are representative of extreme versions of the negative stereotypes of men's personalities. So that they're violent, hostile, and controlling. So not only are we, maybe operating off of stereotypes, but it also means we could be missing these disorders in people who genuinely have them. That's a really good question. Yes, I think that sometimes the policy from insurance companies does lead to misdiagnosis. It's really hard to diagnose someone well in that short amount of time. Again, with practice, you get better at it. But certainly there have been cases where I see someone and someone else, like a psychiatrist, has seen them, and we come up with different diagnoses. So that's a really good question. Plus, the art of diagnosis is fairly tricky, actually, because so many of the disorders overlap in general, much less the personality disorders. So there's also a lack of recognition in the way that the symptoms may be expressed differently between men and women. So we talked about antisocial PD, how these may differ. We heard the woman talk about it, like, I wouldn't necessarily engage in violence, right? And the diagnostic criteria for antisocial PD emphasize overt signs of callous and cruel antisocial behavior. But women with this disorder may be less likely to engage in that overt behavior because of greater social sanctions against women for doing so. Instead, they may find more subtle ways to act out, like covertly sabotaging people at work or even being cruel towards children. So we might be, again, missing these in people that would have them, meet criteria. So are there better ways? The leading criticism, again, of the DSM-4/DSM-5 approach is that it uses multiple categories that serve to dichotomize personality problems. This method does not allow for variations in symptom presentations, including failure to meet all criteria necessary for a full diagnosis. It's been estimated that as many as 60% of clients with personality disorders are not diagnosable according to the current DSM-5 criteria, which is the copy-paste DSM-4 TR criteria. Given such difficulties, many theorists now believe that these disorders probably differ more in degree than in type of dysfunction, and really suggests that these disorders should be organized by the severity of certain key traits or personality dimensions rather than by the presence or absence of specific symptoms. A growing number of these theorists suggest that a dimensional approach to classifying personality pathology would more accurately reflect the personality problems seen in people. So this is the alternate DSM-5 model that's in the back of the DSM-5. And the idea of general criteria for a personality disorder is moderate or greater impairment in personality functioning. And they're defining personality functioning as either within yourself or interpersonally between you and other people. You've got one or more pathological personality traits, and these impairments are relatively inflexible, so they're not gonna vary, and pervasive across a broad range of personal and social situations. They're also stable across time with onset of at least adolescence or early adulthood. So again, still going to be a challenge, right, to diagnose them, but the whole point of personality disorders is based on that theory of personality as itself being something that's sort of persistent over time. So if your personality is disordered, the idea is that has to have started a while ago. So the new model looks at elements of personality functioning, and these are characterized by typical functioning in these areas. So there's, again, one's about the self and one about interpersonal interaction. So identity includes the regulation of self states, a coherence of sense of time and personal history, the ability to experience a unique self and to identify clear boundaries between yourself and others, and the capacity for self-reflection. And again, here's one, for example, that people with borderline PD wouldn't do great on. Self-direction is establishment of internal standards for your behavior, coherence and meaningfulness of your short-term and life goals. Interpersonal include empathy, so the ability to understand other people's experiences and appreciate them. Sometimes this is called mentalizing or theory of mind. It's essentially your ability to like put yourself in the other person's shoes and how are they feeling and thinking. And again, that's hard for some people, like people with antisocial PD. Attention to the range of others' perspectives and understanding social causality. So if I do something awful to someone else, it'll cause this chain of events, not just like, oh, nothing will happen. And intimacy, the depth and duration of connection with others, tolerance and desire for closeness, reciprocity of regard and support, and its reflection in their behavior with others. They also have included a scale, a dimensionality component of how severely these things are impaired. So no impairment, pretty obvious, right? They're doing pretty well. Some impairment for things about the self, there would be a sense of unique historical identity is relatively intact, but there's some variation in self states and interpersonal boundaries, perhaps related to strong emotions. Interpersonally, the ability to appreciate and understand others is somewhat compromised, and others may be seen as having unreasonable expectations or a wish for control. So again, you hear some of that like paranoia, right? Moderate impact for the self would be the regulation of self states depending on context and an impaired capacity to think about internal experience. We would call this a lack of interoceptive awareness in the psychology world. Interpersonally, there would be a considerable inability to consider multiple points of view, an extreme attention to the views of others, but only with respect to perceived self-relevance. Severe impact would be for the self states being poorly regulated and unstable, accompanied by confusion or lack of continuity in their personal history. Interpersonally would be significant limitations in empathy and confusion or unawareness of social causality, including the impact of your actions on others. And then when we get to extreme, self would be a profound inability to even think about your own experiences. Interpersonally would be the ability to consider and understand others' experience and motivation is significantly impaired, and attention to others' perspective is virtually absent. And instead, attention would be hypervigilant, focused on need fulfillment and harm avoidance. You would only pay attention to other people in your own self-interest. So again, we get a nice range of what are some of the ways these things can be impaired, rather than just yes or no. All right, so this is the alternative model. So again, there are 10 in the DSM-4/DSM-5 main text. I know this gets confusing because there are 2 different versions, right? But they would bring it down to 6. So this was kind of cool seeing this develop because I think I mentioned before, they gave a lot of opportunities for professional feedback. And I think at some point they had 5 and then they brought it back up to 6 based on the research that's out there. So they would maintain antisocial. Actually, as you can see, a lot of what they would maintain would be the cluster B. So antisocial, borderline, and narcissistic. From cluster A, as I mentioned, condensing everything down to schizotypal. And then from cluster C, just avoidant and OCPD. And again, what we would see, the 4 other ones that are currently diagnosed would be collapsed into these, right? So maybe someone with histrionic PD, depending on their severity, if they are engaging in suicidal behavior, perhaps they meet criteria for borderline PD, right? Or if it's more just about focus on themselves, maybe they're actually narcissistic. There's also this idea that we could have a personality disorder trait specified. So this would be like sort of the catch-all that people will fall into now, personality disorder not otherwise specified, but now as you can see, it would be specified. So the idea is that if you have moderate or greater impairment in personality function, manifested in the difficulties of at least 2 of these. So identity, self-direction, empathy, and intimacy. Those 4 things we've already mentioned that are the core of what they're looking at. So to get a diagnosis here, you'd have to have 1 or more pathological personality trait domains or specific trait facets within the domains. And you have to look at all of the following. So negative affectivity versus emotional stability. So they experience a wide range of negative emotions like anxiety, depression, guilt and shame, worry, and the behavioral and interpersonal manifestations of those emotions are maladaptive. So trait facets here might be emotional lability, anxiousness, submissiveness, separation insecurity, pessimism, low self-esteem, guilt and shame, self-harm, depressivity, or suspiciousness. Detachment versus extroversion. So withdrawal from other people, ranging from intimate relationships to the world at large, restricted affective experience and expression, limited hedonic capacity. So trait facets here would be social withdrawal, social detachment, restricted affectivity, and hedonia, that inability to enjoy things you used to enjoy, and intimacy avoidance. So here's where some of that avoidant PD stuff comes in. Antagonism versus agreeableness. So this person exhibits diverse manifestations of antipathy towards others and a correspondingly exaggerated sense of self-importance. So callousness, manipulativeness, narcissism, histrionism, hostility, aggression, oppositionality, or deceitfulness. So this is basically cluster B, right? They're not going to have the clusters anymore, but just like mentally, it helps me shortcut wise right now. Disinhibition versus conscientiousness. So diverse manifestations of being present oriented instead of, future oriented or past oriented, so that behavior is driven by current internal and external stimuli rather than by past learning or consideration of future consequences. So here you get impulsivity, distractibility, recklessness, and irresponsibility. And then psychoticism versus lucidity. And this includes a range of odd or unusual behaviors and cognitions, including both processes, such as perception, and content, like their actual beliefs. So unusual perceptions or beliefs, eccentricity, cognitive dysregulation, and dissociation proneness. So those of you who are familiar, have taken theories of personality, or just might remember from intro psych, yes, these map somewhat onto the big 5, right? The idea of the OCEAN acronym. So something really interesting to kind of think about is, again, thinking about personality disorders as just pathological versions of what we know about personality. All righty, so that is the end of our last lecture of the semester, which is kind of mind-blowing. So I will see some of you on Tuesday to take exam 4. Exam 4 just covers the substance use and personality disorder chapters. And then I will see everyone on a week from Tuesday for our presentations at 9 a.m. So I have really enjoyed teaching you all this semester, again, despite how weird this year is academically, right? So I hope that you have still felt you were able to learn within this capacity. I tried to keep things interesting. Yeah. Test 4 is Tuesday. So Tuesday during class. Alrighty, so I'll hang around in case anyone has any questions. If not, I will see you either on Tuesday or a week from Tuesday.
Have a good day, Dr. Myers.
Yeah, you too. Great questions, Romina. Thank you. Hey, Sophia, do you have questions for me?